Hello and welcome everyone to today's Kidney Conversation. This panel discussion is called Organ Donation, Deceased and Living, the Way Forward. This panel discussion has a wonderful lineup of guests and we are really happy to have you here this evening. We are going to be talking with Dr. Danielle Doughton. She works at the Queen Elizabeth Hospital. We'll be speaking also to Dr. Margaret O'Shea, nephrology resident and surgeon, and she also works at the Queen Elizabeth Hospital in Barbados. And also Nurse Ruth Shorey. But today's special guest is Dr. Velma Scanterbury, Bajan by birth, but making a tremendous impact in the field of kidney transplants in North America. I'm your moderator and host, Jason Bell, and it's a pleasure to have all of you here today. We're really looking forward to a wonderful conversation, welcoming your questions via Zoom and also in person here at the Comberemere School Hall. And we're really looking forward to a wonderful conversation. A little bit more about our guests. Dr. Danielle Doughton, as I said, is Specialist Registrar in Nephrology. That's the study of kidneys and kidney diseases here at the QH in Barbados. Her colleague, Dr. Margaret O'Shea, is consultant and transplant surgeon here in Barbados, and she also works with the Commonwealth in the English-speaking Caribbean in up to 10 Caribbean countries and Guyana as well. Nurse Ruth Shorey, she's everything to do with the kidney clinics here in Barbados, and she's the transplant coordinator here for the entire island. And of course, our special guest is Dr. Velma Scanterbury, transplant surgeon based in the USA. Looking forward to having a really wonderful conversation with you. Let's join in and have a listen. Our first guest this evening is Nurse Ruth Shorey, and she'll be speaking, after she does a basic introduction, on the process of seeking a transplant. So how do you go about, as a patient in Barbados, seeking a kidney transplant? But first, Nurse Shorey, tell us a little bit about yourself.
I also do the perioperative part. That's when the patients are in surgery. I am there as well. And I do the immediate and post-op and long-term care for the clients. I also coordinate care. I do like a jack of all trades. I do everything for you. So from the time you come through the door, I am working with you right up until I retire. Because I'm going to be, depending on your age, I'm going to retire and leave you, right? I am primarily the client's advocate. I advocate for you, tell me your concerns. I try to allay your fears. If not, I will guide you in the direction of someone who can. I make appointments for you. I do, as I say, everything for you. Right, that's my job. That's me in a nutshell.
Thank you, Nurse Shorey. To my immediate left is Dr. Velma Scanterbury, one of America's best doctors, and that's not just me saying so, but she comes from right about here. So we want to say a special welcome to you and just give us a little introduction about yourself in about a minute or less. Well, I'll give you 2 minutes. How about that?
My name is Dr. Scanterbury. Actually, I was born and raised in Goodland, St. Michael, before I left Barbados to go to Brooklyn, New York, where I completed my high school, college, and medical school at Columbia University. Went on to do transplantation at University of Pittsburgh. Jason here implies that I'm old, but you know, I'm experienced, I'm seasoned, and so have been doing transplantation for over 30 years. So I'm glad to be here and to contribute in any way to moving the needle forward in trying to see where we are going with deceased donor transplantation and enhancing the living donor program. So thank you very much for having me.
Thank you. 1, 2, 2. There we go. Yeah, you go on to that one. Thank you so much. To her left is Dr. Margaret O'Shea. She's a consultant transplant surgeon here in Barbados. Please tell us a little bit more about yourself, Dr. O'Shea.
Thank you, Jason. I'm Margaret O'Shea. I started in general surgery and graduated in 2006. In 2009, I got the opportunity to do a fellowship in kidney transplantation in Australia. And I fell in love with the specialty then. Everything about it is fantastic in terms of just the giving of the donors to the recipients and the change in their lives from some of that's totally voluntary. And then I came out to Barbados, and we've been trying to start a program here since then. It's been a bit up and down, and COVID didn't help, but we are determined, and we really want to help this special group of patients that have renal failure to have the best life. I also do access for dialysis, so that's an important aspect of renal, the management of patients with renal failure, having good access so they can at least have dialysis, good dialysis, if they are not able to get a kidney transplant. So I'm happy to be amongst my fellow speakers, especially Dr. Scantlebury, who is really a rock star of transplantation. She's kind of humble, but she's internationally known, and the first transplant surgeon, Black female transplant surgeon in the USA. So I'm really happy to be here today.
Excellent. Thank you, Dr. O'Shea. And to her left is Dr. Danielle Doughton. Dr. Doughton, she is the specialist registrar in nephrology here in Barbados. Dr. Doughton, thank you.
Hello, okay. I'm Dr. Danielle Doughton, and I'm a senior registrar at the Queen Elizabeth Hospital, which I've been working at since 2010. I've been working in the Department of Nephrology since 2017, and have completed my nephrology fellowship as of last year, January. And I predominantly work in the renal units, whether that is peritoneal dialysis or hemodialysis. And I also work with the chronic kidney disease patients. So before we get to the stage of dialysis. And I know this talk this evening is predominantly on transplant, but I'm going to give you a little introduction into chronic kidney disease as well, so you can get an idea of where we're coming from and really where we need to start even before we get to transplant. So.
Excellent. So in snake fashion, we will continue with Dr. Doughton as she speaks on issues such as challenges in Barbados in treating kidney disease, the causes of kidney disease, the numbers, as in the number of people here in Barbados, or, well, you will speak to that. On dialysis, I understand there's a lot more than the average Bajan may think. She'll be speaking on outpatients and kidney impairment in Barbados, and of course, the symptoms of kidney disease. So you leave this conversation a lot more armed, having listened to Dr. Doughton. So please take it away.
Okay. All right, so in terms of chronic kidney disease, so the thing that we have to know is that persons who are at risk and persons who we would see most often in our clinic are diabetic patients, hypertensive patients. So, and communicable diseases is a major issue in Barbados. So anybody with diabetes and high blood pressure really needs to get their blood test done to see what their toxin levels are, as well as their urine test done to see what their protein levels are. And chronic kidney disease is really when you have an elevation or impairment in your kidney levels or your kidney function, or elevated protein urine level. And that goes on for more than 3 months. So it's not necessarily a one-time test. So it's very important to let your doctors and GPs and so on know that you need to get your blood test done and your urine test done, and that you need to get it done often, at least every year, but for sure on a 6-monthly basis, and sometimes more than that, depending on what's happening with you. So those are the types of patients we see. So renal, if you have damage to your kidneys, so in elevated blood levels, or if you have protein in the urine. So those things are abnormal. As I touched on before, then we would see in our clinic on a Thursday, we have a clinic for chronic kidney disease, and we can see up to 70 patients in that clinic. It's never less than 50, I can tell you that for sure. And new patients we would see every week are between 5 to 7 patients. Sometimes they can be more. And that is only in the clinic. That does not account for the patients that we would see who are admitted to the hospital. So that on a daily basis, we can at least get 1 or 2. Sometimes it slows down in between, but on a weekly basis, we might see at least 3 new patients that have kidney disease that did not know that they had kidney disease from before. So it's really important for you to know that the risk is there and that you need to check for it. In terms of symptoms, the reason why we see so many patients, especially coming into hospital not knowing, is because you don't really have symptoms from kidney disease per se. You tend to have symptoms at the end where you need dialysis, but leading up to that, you don't really have any symptoms. And the only way we know what's happening with you and the kidney is when you do blood tests or urine tests. So that back pain that you're getting is not really kidney related. That's likely just muscle pain or joint pain. So it is really, really important, and then we have to drive home that you have to get the blood test done, that you have to get the urine test done, because that is the only way we would know if there's something happening or there's a problem in the kidney itself. In terms of the challenges that we have, I think one of the major issues is at a primary care level. I'm going to be honest with you. So even to basic things like getting patients to take their medication and take it seriously, and I think a lot of it is because you do not have symptoms. So patients don't really fully understand that that it is a problem because they feel relatively well until they need the dialysis. So it's so important for you to manage your diabetes and manage your hypertension as best as you possibly can. I know, of course, in the primary care system, it will be more helpful, but we do have things like dietitians and nutritionists and nurses and stuff like that, but it will be helpful if you even have more of these things at your disposal so that you can get continued care and not just like one-off, like every 4 months and stuff like that. But it is key for you to really take it into your own hands. I always tell patients, you come to see us every 3 months or every 4 months or so, but you are, in your body all of the rest of that time. So you have to make sure that all of the rest of that time, you are treating your body well, right? So it's really your responsibility to make sure that you do that, so we're not ending up on dialysis and ending up on with transplant. But of course, we still have that option if we need it, yes? In terms of the number of patients on dialysis, we have approximately now, I would say like 350 or so patients on dialysis in general. Right here now, I'm seeing a lot of hemodialysis patients, but we do have something called peritoneal dialysis, which is a type of home dialysis. We have about 63 patients on that program. At the Queen Elizabeth Hospital in the hemodialysis program, we have about 163 at this point in time. And at SILS, I am approximating based on our last review is about 60 something as well, which is the private dialysis center. And even though it's private, the majority of the patients are public patients, so the government pays for that as well, right? So we do have quite a bit of people on dialysis, and it is it's not cheap, it's expensive. So it is important for you to really take your own health into your own hands. And luckily, we have the option of transplant. So if you do end up to the point where you have stage 5 kidney disease requiring further treatment, yes, we have the dialysis, which everybody knows, which is the blood dialysis. That's the most common one, as well as the peritoneal dialysis I mentioned. But transplant is also an option, and that's what we're here to speak about this evening. So predominantly, we have living donor transplant, and we're trying our best to see if we could get legislation passed for the deceased donor so that they will have more options available for patients in general. And that is my bit.
Thank you so much, Dr. Dottin. Now, audience online and audience here, I am going to crave your indulgence and ask you to hold your questions. I have a few, and I'm going to hold back my own instinct to steal the show from our next guest because as we said, we are going in roughly this direction. We may make a skip and then come back to our final guest, but make a note of your questions and be sure to raise your hand and I'll come to you, okay? So you can ask the question so everyone can hear. Dr. O'Shea, over to you.
Okay, thank you, Mr. Haynes wanted me to speak about my role in with the Caribbean regionally. So last year I was appointed the Caribbean coordinator, Commonwealth Caribbean coordinator for the transplant programs within the region. Well, it helped me to reach out to all the Caribbean countries who have patients with renal failure, because not every Caribbean country does have access to a transplant program. Basically, Jamaica, Trinidad, Guyana, and Barbados within the English-speaking Caribbean are those countries that have programs, and Antigua. But all of the countries do have this issue of escalating NCDs and end-stage renal disease. And through the EU, I've also reached out, become aware of programs as close as Martinique and Guadeloupe. So there's a lot going on in the region we're not aware of in terms of transplant activity. Trinidad had legislation, one of the first ones in the Caribbean, for deceased donation. A large dialysis population, as Daniel Doughton just mentioned, but we are not able to transplant a reasonable percentage of those patients. That because of lack of donors is one roadblock. The challenge with end-stage renal disease and the majority of our patients having it from NCDs is that you find that in their relatives, and they're the likely ones that they may look to if they do, but because some people don't want to, they're afraid to ask for donors, and they may have some similar issues. Similarly, so that limits the donor pool. And the truth is, to be a donor, you have to be in perfect health. We will not put you through the operation if there's any chance that you may end up on dialysis yourself. And certainly we want the operation to be extremely safe. It should be as safe as just taking out your gallbladder. So, but to find that person in perfect health is not as hard, it's not as easy as you might think. It's actually quite difficult. So that is a challenge in terms of living donation. But we do have, as you mentioned, the option for deceased donation, which is with a person who is really brain dead, with the heart still beating. And this is an opportunity for something good to happen out of a tragedy. And for our situation, that would be 2 kidneys that could be given to patients who don't have a donor. So donors, the donor pool needs to be widened for us to improve our percentage of our transplant program. And also we need a national transplant unit to expand to all the specialists that we really need. Dr. Scantlebury will tell you how much is really involved in first world countries. And Ruth has mentioned in UK where you have a lot of staff and a lot of support and finance. But at the end of the day, it is cheaper than dialysis. And quality of life is also improved. So in Trinidad, took a little lull with COVID as everywhere else, but they're back up to pretty much pre-COVID numbers. They do have the only deceased donor program in the region. Guyana has legislation, but they have not started the program just yet. But we're all very cohesive in the Caribbean, and we know each other, and we have our meetings together. So we kind of tap into each other in terms of camaraderie and cooperation. And we hope maybe one day even to have some organ sharing within the region. And we're so close, we don't really see why it should not be possible. So that is something that I continue to champion within the region and through the different stakeholders within the region. So I hope maybe one day before I retire, something like this might happen for us. Thank you.
Thank you so much, Dr. O'Shea. She was speaking from a regional level, as you may have recognized, regarding the number of transplants performed in the Caribbean, the plans to increase the number of donors and to implement cadaver donors. I found it very interesting that there's 2 countries that we will consider in the Caribbean region, even though Guyana is technically in South America, they still consider themselves, we still consider them part of the English-speaking Caribbean. Yeah. And while they have the legislation, the actual practical steps have not yet been taken?
No.
Right. So Trinidad is the only island, and I would dare say for what it's worth from this average guy, to whoever it may concern, let's make this happen sooner rather than later here in Barbados. Now, the only to my immediate right again, because we allow our guests of honor to, what's it in baseball, back cleanup? I think that's what they call it. Yeah, back cleanup. She'll end our presentations here. But to my right, Nurse Shori will speak to the local experience as it currently pertains to the process for seeking a live transplant, because that's the only one that's possible right now in Barbados, as far as I'm aware.
Yeah.
So the process of transplanting in Barbados, Nurse Shori, bring your mic a little closer to you if you don't mind. It won't bite. Take it away.
Right, so
A little closer. The mic to you. Good job.
right. Right, so here in Barbados, as you have heard, we only do life donation. So most persons who are interested in having a kidney transplant, they're referred to me as a transplant coordinator, either by Dr. O'Shea as a surgeon, because they would have seen her first, maybe a placement of access, or they would have been seen by the nephrologist in clinic. Or sometimes they reach out to me themselves, say through word of mouth. Our dialysis population, they have a network that works really well. And they know things that you wouldn't think they know, and they know people. So somebody would say, oh, go and see this body because X, Y, and Z. So some of them tend to reach out to me in person. So once they reach out to me, an appointment is given. I usually encourage the potential recipient to bring along the potential donor at that meeting, because I want everybody to get as much information as you can. I want you to go home and think about it. I don't want the decision made on the spot. Even though some people do come saying, yes, I've made up my mind, I want them to go home and think about it. It is something that you just cannot get into just like that, especially for our recipients. I am a big fan of compliance. My biggest beef is if you are having issues with your dialysis compliance, that is, you don't come to your treatments, you don't follow the instructions, you don't drink your fluids as you should, you don't eat what you're supposed to eat, you're always having problems on dialysis, how are you going to manage at the end if you've had a kidney transplant? You're going to be on medication for the rest of your life. You're on medication that you cannot get up today and say, I don't feel like taking it, because that's not part of the discussion. You have to take your medication. If you don't take it, your body will recognize that that kidney is not yours, and it will start the rejection process. Once you come and you decide, well, this is what we want to do, this is the next step. We're going to do some blood type. Some people know their blood type already. And in Barbados, because of our limited resources, we do the transplant you have to be compatible on the ABO group. That's your blood type. Other places, you can do the transplant if you're not the same blood type, but we are very particular, and we want that you be the same blood type, and you are compatible on the blood type. We also check some certain tests to make sure that your kidneys are working properly, that you're not anemic. Dr. O'Shea mentioned, I think it was Dr. O'Shea that mentioned, our donors, remember in our population, we have persons who are overweight. And one of the parameters for being a donor is that for us in Barbados, is that you must have a body mass index of 30 or less. That's about 100 kgs. And many of us are over 100 kgs. Many persons come forward, they say, yes, I want to be a donor, come forward willingly, but the weight is an issue. And sometimes I may set you certain goals to meet before we can really go forward in the workup. And number one is getting that weight down to acceptable body mass index. Because if you are overweight, it has an implication at the end of your surgery. Even though your surgery is not an open surgery like before, we do laparoscopic hand assisted retrieval, but we still do not want all the complications that you would get from having an enlarged tummy and all the things that go along with that. Sometimes the blood pressure might be an issue. We generally do not take a kidney from someone who's on more than 2 blood pressure medications for the obvious reason. high blood pressure, if it's not controlled, damages the kidney. If you are diabetic, for the obvious reason, diabetes is a high risk factor for kidney disease. So we would not do that. And you'd be surprised, there's some persons who don't even know they're diabetic till we do the blood test, HbA1c is high. And then they do the screening to realize that you're having high fastings, and it is what it is. And sometimes you have to tell persons, because of whatever the issue is, that we cannot proceed with you. The road to transplantation is not always smooth. It can be very bumpy, or sometimes so many potholes you will not think you're going to get to the end. Sometimes you may not get to the end. We may find an issue with the donor. The donor may have underlying heart problems that renders them unfit for surgery. Your heart must be strong to stand the rigors of that surgery. That surgery is about 3 hours on the table laying down. Your heart has to be strong. Or we may find that the donor may have a malignancy. We don't take a kidney from someone who has active cancer. Same thing with the recipient. Unfortunately, many persons on dialysis, whether PD or HD, will not be transplanted because of the comorbidities. And that is a fact that we must face, because when you're on dialysis, the process, all the inflammatory and all the stuff is going on, it causes damage to your blood vessels. And sometimes it doesn't put you in a good position. And we have a motto of the best outcomes possible. We don't want to do any harm. So if we find something is wrong that puts you at risk for a bad outcome, we are not going to take the kidney from you, or we are not going to put you to sleep to give you one. Because especially the medication that you go on, if you have, say, a condition that putting you on immunosuppressive medication can cause it to flare up that would cause you to have a bad outcome, I don't think we will not do it. We want the best outcomes possible. Another thing that we look at is when you come to me, you must have, I like to say, my friend from England to say, you must have capacity. You must have the ability to understand what is being said, because you don't want to go into the situation of coercion. And when I say that, I mean, okay, you say you want to be a donor, but you don't fully understand what is being said, and you're taking somebody's word for what I am saying. And the person is going to tell you things that they want you to hear, that they want you to hear for you to make that decision. But in true fact, if you really understood what was being said, you will not make the decision. And what you understand when they say that, right? So you must have the ability to understand what is being said. On the other side of that, persons with psychiatric problems or mental illness, they're not considered good candidates to be donors, because again, you have to be able to understand what is being said. Let me just step back here. In Barbados, we have age limit. So we will not take kidney from someone who is, well, that is our policy right now, of 21 years and under. We like that. When this was said at first, it was that we felt that at 18, you're now becoming an adult, yes, but you still have life to become more of an adult, to have more experiences in order to make that decision. So we felt if we give you a little bit more time at 21, when you come, you will be in a better position to say yes, because a lot can change between 18 and 21. You can say yes at 18, I want to do this, but somewhere along the line, you and that person, no obedience, follow. At 21, your perceptions of that person might have changed, and you would have changed your mind. So we prefer you to come when you're at 21. Right. So you do your workup. This is a good situation. We do our pre-transplant workup. You're a good match. We're good to go. Everything checks out. We do the operation. Everything's fine. The kidney works fine. But there's some situations where the kidney doesn't work as it should. And persons, if they have a hemodialysis access or PD access, we will have to do emergency dialysis via those so that kidney settles down and does what it is supposed to do. Here in Barbados, our patients are treated like royalty. Our donors, we have an unwritten policy. We guarantee that our donors are treated by us. They come for us for annual checkups for life, or unless they decide they don't want to see us anymore. But they're encouraged to come and see us because you only have one kidney, so we need to take care of you. Our recipients, you see us more frequently, but you have no choice. You need to come and see us because we need to take care of you. You can't manage this on your own. You need the experts to help you to deal with this. On the day of surgery, you have the luxury, those who are going forward for the surgery have the luxury of being cared for upstairs on the private wards. So there you have your own room. So the person who's having the kidney has their own room. The person who is the donor has their own room, but they're not together because you need to get up and walk to see each other. And from there, you will go to the surgery on the morning of your operation. We start very early with our donors. The nurse that works with us, she has everything down pat. So I think when 6 o'clock, she's sending for the donor. We start around 8. And once everything is good, we're out by 11. The donor goes to recovery room. So once you recover in recovery room and you're stabilized, you go back to your room on the private ward. We start our second surgery at 1 o'clock, around 1 o'clock. That takes a little longer, but that because we like you that much, so we spend like extra time with you. We want to make sure that everything is right before you leave the surgery, but you don't go to recovery room and you're finished. You go to our intensive care unit on the 8th floor. You spend about 3 days there. Once you stabilize, you go back to the ward, and this is where you see me all the time. You'll be seeing me from the time you open your eyes in SICU. You won't see me at night, but you will see me from the time you open your eyes and you're aware of what is going on. You see me when you go back to the private wards. You see me every day. You see the doctors every day. We do rounds. Your nurses on the private wards, they're skilled. They know what they're doing. So when I'm not there, you're in good hands. And we start our discharge planning in earnest when you go back to the ward. That is how you're going to take care of yourself. It's your rehabilitation. It's how you're going to manage at home when you leave the hospital. I'm not going to be there with you overnight, but I'm just a phone call away. But you need to be able to get back on your feet and go back to be able to function. And that's one of the things about transplantation. When you're on dialysis, you have to plan your life around a dialysis machine 2 times a week, 3 times a week, 3 hours, 3.5, 4 hours, or a PD machine at night. So you can't really go anywhere. If you used to travel, you have to plan to go to a center that can take you at the time you want to travel. If you used to travel with $4,000 spending money, well, a lot of that is going to go to pay for your dialysis treatment. So it is, or if you're on PD, you have to travel with your things. So if you get a transplant, it is to get you back to your routine, what your routine would have been before you got sick. Go back to work. You can be a responsible, functioning member of society. If you've not had children, you can have children. Donors can want to have children too. If you were a donor and you didn't have any children, you still, once you settle down, your body's recovered, you can go out and you can try to start a family. Now, I must say this, while our payers are being worked up, and I try to keep them within the 18-month time period, but it can take a little longer sometimes. I usually stress, urge, nudge that our peers, especially if females involved, try not to get pregnant, no matter how close you are to the end of your transplant workup. If a donor or potential donor, potential recipient should get pregnant, the transplant workup stops until they have delivered safely, and we wait a year, and we have to start again. Another reason why we encourage them to practice safe sex is because if you have done our compatibility test, that test is not done in Barbados. It costs about $5,033. That was the last figure that I heard. That comes out of the public purse. And if you go and you get pregnant after you've done that test, you have to wait another year now, and you have to do over that test. Sometimes that $5,033 is not always readily available. Hospital may have to pull money from somewhere to pay for that because they recognize transplant is a priority. So that's the reason why I would stress that you please practice safe sex. And while I'm on the topic of money, I don't like talking about money, but our drugs are not cheap. Yes, in the long run, they're expensive, but in the long run, the treatment pays for itself. The treatment costs less. But some drugs cost in excess of $3,000 for a month's supply. So if you know that you cannot take, and this is the discussion that we have. Anybody who in here who has been to my office, and we've had this discussion, you notice what we talk about. If you know that you cannot, and you will not be compliant with your medication, if you know that you are not going to cure the kidney, don't put your donor through that surgery that they don't need just to improve the quality of their life. They're doing it for you, to help you. Your unwritten contract with the taxpayers about medication, it's free. Some of this medication, other people have to pay for it, but it's free. The hospital is finding ways to get this medication for you. If you know you can't take the medication, be honest with yourself and be honest with your donor, and don't put them through that. That's how I feel. I feel strongly about that. I don't know how y'all feel about that, but I sure you want to like to know you've given somebody your kidney, you put yourself through that surgery, and then watch them just, throw it away. You'll be angry. Sometimes you wonder if it's something that you did. Donors will feel that way. If it's something that I did that caused that to happen. But then when you realize what the truth really is, that guilt can turn to anger because that's what you did, right? So we're going to close up now. Because there's a lot to talk about, but I just try to proceed it, sharpen it up, get the points across. Being a donor is not something that you just get up one morning and say. It is not a half an hour or hour like how you see on television. It takes time. We dot our I's, we cross our T's, we dot them again, we cross them again. If we think that there will be an issue, we say, wait a minute, and we go back and we check again. Because we do not want no problems on that table. We tell your family, your relatives, you can sit outside. I will go and tell you, yes, everything went fine. I like to go and say everything went fine. I don't want to go and say we had a problem. I don't want doctors to come and say we had a problem. We want everything to go fine. If you know you cannot be responsible to take the medication, to keep your visits, don't put your donor through that. Please. That's it.
Nurse Shori, thank you so much. That was comprehensive, and yeah, it raised more questions than answers. But I, again, along with us online and in person, will hold our questions to the end. As a bit of online housekeeping, we encourage you to put your mics on mute. Put your mics on mute so that there's no feedback coming back into the auditorium. We had a couple of frightful noises there a few minutes ago. So we want to make sure that everyone cooperates so that we can have a wonderful experience. Lady of the hour is on my immediate left, with all respect to the other lovely ladies. Dr. Velma Scantlebury will be speaking about her experiences in her profession, the improvements in transplant surgeries over the years, and of course, future developments in the transplant industry, because indeed this is a very, like any other marketplace, the kidney transplant can be seen as a marketplace, and professionals like her are industry professionals. So please, with your 3+ decades, and I'm in no way trying to age you on purpose, but you need to speak to your seasoning, to your experiences in that industry, coming from about here over in a way, and bring your talents and experiences back home. So we welcome you once again, and thank you for sharing.
Thank you so much, Jason. No offense taken. Don't worry. It's just good humor, good humor. Dr. Dottin spoke earlier about diabetes and hypertension, which are the two main causes of kidney disease, being without symptoms. And, that's the hardest thing for people to understand, that while there may not be anything that's obvious until end stages of your disease, you have to remember that diabetes and hypertension are two leading causes of cardiovascular disease and heart disease, and the mortality of the primary cause of death for patients on dialysis is cardiovascular disease. And so while you may not necessarily have any symptoms, you have to realize that there are things going on inside your body that's deteriorating. And what diabetes does is it slowly damages your blood vessels, and to the point where your end blood vessels, those that get smaller and smaller out, gets more damaged. So you get vision loss because now you're in the capillaries of your eye. So diabetes causes vision loss. Diabetes will cause stroke. Some people get neuropathy in their feet because the blood vessels supplying your nerves in your feet aren't delivering enough blood, so you have numbness. You have loss of blood flow to your legs, and which is why people suffer from loss of toes, loss of limbs, amputations, because your blood vessels get damaged. So while you may not be symptomatic, also realize there are things happening. You end up with a heart attack, which for most people, I mean, some people, when we come to transplant, to work up for a transplant with a diabetes, and you have those stress tests, you find that they've had silent heart attacks in the past, but now they don't have symptoms because diabetes also injure your ability to feel as well. So with diabetes, you may not have the same chest pain or jaw pain and symptoms that people without diabetes may have. And so your blood vessels are slowly being destroyed. High blood pressure also is a silent disease, the same thing. It's almost as if your plumbing goes from this wide to this wide. And so now you have resistance in your blood vessels for that blood to pump. And you're almost as if you're jogging 100% of the day. So if your heart's working hard constantly with that high blood pressure, and then if you have high blood pressure and diabetes, then you're causing more work on your heart system, your heart and your blood vessel system. So what's the number one cause of death for people with dialysis? The longer you are on dialysis, the more likely you die from underlying cardiovascular disease due to issues affecting your heart and your blood vessels. So it's about longevity. If you're under 50, your time on dialysis, you may have, you say 98% of people will be alive at 1 year. It may be 30 to 40% may be alive at 5 years. But if you're over 50, the chances are 50% of people will be dead at 5 years on dialysis. It's about how can I live longer? Transplant offers you the ability to survive at least minimum 80 to 90% of people will survive. And now that in the United States, it's a 95% survival rate at 1 year. Here, it's probably about there. The longevity, and so what that dialysis is, what transplant is doing is restoring your body to normal. Dialysis filters your body and taking off that waste products 2 or 3 times a week. Imagine if you're just going to have a bowel movement 2 or 3 times a week. Your body is accumulating waste products, and those toxins accumulate in your body. While you may find that you're doing okay, your body is certainly paying a price for that dialysis. So I think it's really important for us to think about how can we provide better longevity for people. We know that, as you know, dialysis is a treatment, and I'm going to say, Dr. Dodden said transplant is an option. Transplant should be really the top of the line, because that's going to give you better longevity, better quality of life, restore your mind and your body to a sense that now you have a kidney that can filter. That dialysis is only doing partial. So if your creatinine clearance on dialysis is, what's the creatinine clearance on dialysis? 20, 25 at best if you're well dialyzed. That means 75% of your toxins are still remaining. So the glass is only, your body is only filtering off what's on the top, and you're not getting rid of all those toxins accumulated in your body that a kidney can do. And so we have the disadvantage is that we're constantly going to, because society, and I don't know what the incidence of and prevalence of diabetes on the island, we know it's high. is it 30%? I have no idea.
20 adults.
It's 20?
Of the adults.
20
but
of the
it's
adults, so
about
that-
50 over 60.
So 50% of people over 60 will have diabetes. And so you are putting yourself at risk. So we know more and more people because of diet, lack of exercise, or how we live, whether it's high blood pressure, diabetes, being overweight, those are risk factors for kidney disease. And then once you get kidney disease, if you didn't have heart disease before, because of the accumulation of all those toxins, yes, you are going to then develop heart disease. So it becomes crucial to say, what's the best treatment, and how can we encourage transplantation? How can we provide that as a better option for longevity? Because otherwise, with more and more people needing dialysis, we're going to run out of spaces. We're going to run out of the ability to dialyze patients, and we're going to see a drop in population because, you know, people are literally being lost to kidney disease. And so it's really in the United States, it's trying to advocate to say kidney transplant should be the #1 treatment of choice. It should be the gold standard. But I know there's always the obstacle of money, to the point where, you know, here in the United States now, there's a big controversy going on about the inequities of transplant, how many people are waiting for a transplant, number of people who die every day waiting for a transplant, and how can we make it better? How can we make more availabilities? You know, we have deceased donor transplantation. We have many rules and practices that allow for people to sign their organ donor card, so that they understand the benefits of organ donation. They understand the benefits of saving lives, to allow other people, because we can't take these organs with you. God doesn't want this body. It's our spiritual being, it's our soul that's going back. So many times you hear folks say, you know, I'm taking everything with me. Where are you taking it? From dust we came, and to dust we will return. And so what better chance to give someone an opportunity to benefit from your passing on, you know, as long as your brain is intact, and as long as you have 2 kidneys if you're alive and you want to be able to donate. We have what we call altruistic donation, where people come forward because they know someone else can benefit from the kidney. And if they have 2 kidneys and they're in good health, they don't have diabetes or problems with high blood pressure, and their heart's good, and, you know, all the other things, they don't have cancer and either have to be in good health to donate, then we have people who say, you know, I just want to help someone else. I just want to give someone a chance, whether it's a coworker or friend or a son or daughter of someone that they know. And that's an opportunity that we all have to do good. And there many years ago, University of Maryland had an ad in New York Times. It was a picture of 2 kidneys. God gave us 2 kidneys. Someone else needs one. And so it was just a simple message, you know, we need 1 kidney, but somehow we have 2. So there's that opportunity to help someone. And I think it's important, as we know Guyana is almost there and Trinidad is there, that we really advocate. We really want people to think about saving the lives of their loved ones. You know, if you're not in that positioning, it's going beyond family. It's not just donors within families, donors and friends. So, you know, use your resources, whether it's church members. We have so many people in the United States who get donors because other church members come forward and volunteer to be their living donor, co-workers, you know, parents of other friends, those kind of things. So you don't have to have a blood match, in the sense that you don't have to have the same blood type. You just have to be compatible by your genetics, and say that there's no antibodies, and that, we know that O can give to as a universal donor, but if you're blood type O, you can only accept from O. So we want you to be compatible, but there's nothing that says you have to be a family member from that standpoint. And we've gone so far in the United States is that now we have treatment for hepatitis C. So donors who have hepatitis C are able to donate to recipients who don't have hepatitis C, because there are drugs that can treat hepatitis. And we know that that can be treated within the recipient if they develop hepatitis. Not to say that every recipient who gets a hepatitis C positive kidney will get hepatitis, but there's no reports out there from that standpoint. We don't do it for hepatitis B, but we do it for hepatitis C. And so it's important to really think about how can we advance here in Barbados, what are the barriers? And I'll entertain a conversation with Dr. O'Shea about how can we move things forward, because we know that longevity with transplant outweighs the advantages of whatever dialysis will offer. And if we don't have enough living donors, then we want to advocate for living donors, because that's the safest. Certainly a kidney from a living donor does better, because that donor doesn't have diabetes, doesn't have hypertension. They died from usually trauma causes. But certainly we take kidneys from people with high blood pressure and diabetes. We biopsy them, make sure that they're not significantly damaged, because the advantage they will provide for that patient outweighs, certainly is much better than being on dialysis. And we know that restoration of kidney function, it will with the kidney transplant will not get to that same level with dialysis. Certainly dialysis in the United States, we're advocating for home dialysis, daily home dialysis with the hemodialysis at home. So that, peritoneal dialysis is done at home, but if you are eating, you need to cleanse your body. So if you eat every day, the best situation is to be able to have that dialysis at home, so you get rid of those waste products. And the difference in survival is really different for people on PD and peritoneal dialysis and hemodialysis. Hemodialysis is the one that drives the work of your heart, because you gain 10 kilos, 5 kilos, let's say 5 kilos, that's 12 pounds between dialysis treatments. That's 12 pounds of water fluid that your heart now has to handle. What does that do to your heart? Is those, until you reach dialysis again, is working hard. It's pumping, because you're not peeing, you're not sweating, you're not burning up that fluid. And so your heart is ballooned out. And so now you go on dialysis, and 4 hours later, you take that off. And then you go through a period, so your heart's like an accordion, it blows up, you gain the fluid, and you take it off. And then over years, what happens is, you see with patients on dialysis, is that hemodialysis, is that you lose that pumpability of your heart. And so your body, the ability of your heart to pump gets weaker and weaker of years on dialysis. And some patients spend the time, if they've been on dialysis a long time, is their heart disease that may make them a poor candidate for transplant. So it's really important to be compliant on your dialysis. It's really important to watch your fluids. It's really important to keep your heart in good condition. I think it's upon us as citizens of Barbados to really figure out how we can advance legislature to really enforce, or not to enforce, but to pass those laws that are needed, so that we can move ahead with providing deceased organ donation, because it would allow for many more patients to get transplanted. What's your thoughts on this, Dr. Shea?
Fully supported.
Well, thank you.
Let's give all our panelists a lofty round of applause. We invite all of you online and in person to raise your hand at this time. Brother Alan, sis, you have a question from the online?
One for the WhatsApp. Question one, is it okay to have, for you to have some protein in your urine, as that some doctors say? I guess how much is too much, perhaps? That would equate to, kidney disease or anything like that. And the second one, the person wants to hear from the surgeons present, what is described as brain dead? I guess it relates to deceased donor donation.
Right. So for the sake of those who could not hear, Sidian, she's one of the floor members of the BKA. According to the WhatsApp group well, it doesn't matter which WhatsApp group. The question from WhatsApp, there were 2 questions from WhatsApp. One was on how much protein is too much. And then the other one is, and there's a question I was thinking to ask about what is defined by brain dead. So we've got 3 medical practitioners on my left here. So go ahead, Dr. Dottin.
Right. Hello?
Yes,
Okay.
you got it.
In terms of the proteinuria, the thing about it is when you go to the doctor, they're gonna do what they call a dipstick. So they're gonna check the urine in the office and see if there's protein in the urine then. That gives a kind of broad idea of if there is protein or not. But from there, then they need to do a more specific test and send it to the lab to determine how much protein there is and the type of protein there is. So specifically, it is on the onus of the doctor, I have to say, to actually send it for the additional test. So once you do the dipstick and you see protein, then you should get an additional test. There's no way that they should not do anything additional and say, okay, that is normal, okay? So in terms of the additional tests, you would usually do albumin creatinine test of the urine, because albumin is the protein that we detect earliest, essentially, when there's a problem with urine. And so when that level is elevated, then, you know, you will have some level of kidney disease. So really and truly, you know, you have to, once they do the dipstick, they have to check and make sure that nothing else is going on. Don't get me wrong. Sometimes if you have a urinary tract infection, or if you have your period or something like that, you might get a bit of protein in the urine. So it might depend on what is happening as well with you as a patient. But again, your doctor should be able to say, okay, right now I suspect it's because you have a urine infection, and they check to so they should still send something to the lab to say, okay, you have bacteria in the urine, or that, to confirm why that is happening. So once they check it and there's protein, then you need to have an additional test. That's as much as I should say. So yeah. They shouldn't just tell you, that's normal, that, you have a bit of protein, that's okay today. No, that's not an option.
So
okay?
there's no baseline amount of protein in a otherwise healthy individual that can be considered normal.
Yes, exactly.
Zero.
No. No.
I hope that was clear enough.
Yeah.
All right. The second question regarding what is brain dead, Dr. O'Shea?
Okay, so for you to be diagnosed brain dead, you go through a series of reflexive. So to even start the testing, the patient has to be unconscious. And unconscious with no cause, like no electrolyte problems, they're not on any medications, they're not drunk, they are otherwise fine, and they're unconscious. Usually precipitating things would be a car accident, a trauma to the brain, maybe like a drowning, or maybe they've had a stroke, or maybe they had some tumor in the brain that, and then they had to get taken out, and then they had some complications. So there's always some brain issue that precipitated them actually end up on a ventilator, because when you're brain dead, you cannot breathe for yourself. But there are obviously some brain injuries that you can recover from. So once you meet these basic criteria, basically you're unconscious, usually your pupils are fixed and dilated, there's no reaction, then it's sort of flagged for the specialist to come and confirm it. And they put you through a series of tests, primitive reflexes that everybody should have, but these people will not have. And ending then with what we call the apnea test. Basically, if I stop you from breathing, maybe you're underwater, you realize at some point you have to breathe. When you're brain dead, that does not happen. So basically the ventilator is turned off, and then you wait to see if the patient will try to breathe. If they do try to breathe, and they're still not really focusing, it may be that they're in a vegetative state. That's not the same as brain dead. So basically vegetative state, you can survive off a ventilator. Once you're brain dead, though, you're not going to be taught, and you put the ventilator back on, and then the diagnosis is made. And once that test is done accurately, there is no recovery. You are in jurisdictions where it is law, the brain death certificate is signed. So that is why you're able then to do operations to retrieve the organs, because you cannot harm a living patient. You can retrieve organs from somebody who is dead, not somebody who is living. So that death certificate has to be signed, and then retrieval, the family can be approached where the jurisdiction will allow. Some people, the jurisdiction, you just there's some jurisdictions where it's presumed consent. So the population knows if that diagnosis is made, you'll be approached. So that has to make, but sometimes the checklist for the reflexives isn't working. And then we can do other tests to see whether there's any blood going to the brain, called an angiogram, or they may do an EEG. If that's flat, it means the brain isn't working. So that is brain. So there's brain and there's also brain stem. Again, those primitive reflexes are checked. So there are different definitions, but basically it's around that you are having a machine to breathe for you, and all these tests that we do, we realize that there is no function to the brain. And at that point, and this has been passed since 1950, and it's accepted criteria worldwide. And once the diagnosis is made, there is no recovery. The patient will never, they cannot survive.
You know, I wanted to say that just to add on to Dr. O'Shea's, for most patients, if you think about the fact that your brain is enclosed in a hard shell, your skull. So if you have a trauma, that brain bleed, gunshot wound to the head, and there is bleeding, there's no room for the blood to be contained in your skull. And so as you bleed, that it crushes your brain because your brain is kind of spongy. And so the blood cuts off, you take a sponge and squeeze it, it cuts off the blood flow to your brain. And so it only takes a few minutes with lack of oxygen to your brain, that even though you may do CPR on a patient, they already have lost enough oxygen to the brain, such as in a drowning, to not be able to recover. The heart may recover, but then the brain doesn't recover because now the swelling has caused so much edema. You injure your arm or you break your arm, you're going to get big swelling. And it can swell because you don't have something restricting the swelling, but your brain restricts it. And so in some patients, I know in the United States, you may have the cortical portion of your brain may suffer, but your brainstem may still control for breathing, but you're not really, still don't have any cortical blood flow. And in those cases, you cannot pronounce the person dead, because as you disconnect them, there was still the brainstem in the back that sticks out the skull. And so it may still signal the patient to breathe. And so we would not declare them brain dead, but we know that the neurologist has said there's no brain flow, so they would not survive long. And we know that if you take them off the ventilator, they will cease to breathe within a short amount of time. I mean, we would call them non-brain dead donors. So we would take them to the operating room, take them off the ventilator with the consent of the family, allow them to stop breathing, allow the heart to stop beating. They're pronounced dead. They're pronounced by a doctor, and then the family leaves and we take the organs rapidly. But those are now becoming much more prominent. But the idea for, at least here in Barbados, is to be able to allow for brain death laws to be put on the books, so that there'd be idea to provide more donors for patients.
I have so many questions, and I'm sure that you do as well. So I will go ahead and allow any questions from the floor. Yes, sir. You go ahead and say it and I will repeat. Or rather, I think your man here has a microphone. Wonderful.
I've been reading about
Hold on. Go again.
hearing about xenotransplantation and kidneys. Is there any hope that would help address the undersupply of organs available?
Well, there's definitely a pig. I know that's been talked about.
Okay, so for the hearing impaired, xenotransplantation.
Xenos from a different species,
Oh, wow.
not human. Yes.
Okay,
And because the demand is so huge and the supply is so low, all things are being explored. And definitely there's a lot of advances now with kidneys from pigs.
right.
And they're pretty close to human.
I was just going to ask you, what
Yeah.
was so special about pigs that make it?
Yeah, they're pretty close to humans.
Well,
And
you can also genetically manipulate
them as well.
in terms
Yeah.
of taking out those genes that are likely to cause rejection. So then you breed the pig, I guess pig can generate piglets quite fast, I guess. And so you can go through a couple generations where the pig you have removed those genes that are responsible for rejection.
And
So
I'm sure you don't have to worry about things like consent.
maybe the one who owns the pig.
Artificial kidneys was also raised as a question. I'm not sure what technology, but you guys are the experts.
Well, there's a 3D printing, but they're not right there yet with these small vessels. So that's the challenge with them. But yeah, you can print something that looks very much like a kidney, but they think they have to get the technology down pat still for the little fine vessels to make it actually happen.
You know, there's so many parts of the kidney that does so many different cells in the kidney that does so many different jobs. If you think of a medication, it may be worked through the kidney, but they may work through the ascending loop and the descending loop and the glomeruli. So, you know, while you can 3D print an ear or a trachea, your ear may not have hair on it, but that's okay. Nobody's going to say, you know, you have a hairless ear. Sounds funny. But when you think about a kidney and 3D printing a kidney, so many different mechanisms that have to be in play. And I know there's a lot of work being done also in terms of the implantable devices where you artificial implant where you put in and you put it in and it filters the blood, sort of like a small dialysis machine. But it still has to be like connected to your bladder so that the urine goes someplace or the extra fluid goes on. So we haven't quite gotten there yet. They keep changing things to make it more and more. But I think if we can just get to the simple stage 1 first before we go to stage 2 and 3, would be great.
There's a question here from,
Mr. Moderator. Mr. Moderator,
yes, sir.
this question is not directly related to dialysis or transplant, but I thought it was so interested. It may interest some of us. So it's online question here, and it happens to. Someone was saying that persons take certain medication to flush out their system if they're on diabetes, if they have diabetes before they go to the doctor, and this tends to mask it that the doctor is not able to determine that they're not being compliant. Does this make sense?
I hope the question wasn't directed at me.
No, sorry. It wasn't direct, sorry. It wasn't direct.
I will let the good doctors and the nurse answer that question. Take a stab at it.
Hello? Okay. Yeah, no, that doesn't make any sense.
Yeah, it is partly test for me either, to be fair.
No. Yeah. There's no way to mask kidney disease. You either have it or you don't. There's no way to mask it. The thing about kidney disease is Dr. Scantlebury gave a very good thing. The diabetes and hypertension, they're causing problems in the body for a long time before you even start to see issues, okay? And that's why we call them silent killers, as she said. So there's no way to mask it because the problem has been going on from the time we say, okay, now you have kidney disease. Yes, we are now telling you that for the first time, but that doesn't mean that is when it happened. It has been happening over years, okay? So there's no way to mask it with flushes and stuff like that. To be honest, you're likely doing yourself more harm because you're gonna make yourself dehydrated and so on. So I wouldn't recommend anybody doing any flushes or anything like that because it's not gonna mask anything, okay? So the thing about it is to know that this has been going on for a long time, and I wanted to say, so I guess this gives me form. The key here, we're really talking about transplant, it's true, but the key is really prevention. So I really want people to realize we don't want you to get a transplant. We don't want you to be on dialysis. You know, we don't want that for you because it comes with more complications, at least dialysis part of it. And even the transplant, because you have complications related to that too. So we don't really want you to end up there. That's not what we want. We want you to prevent it, essentially. So you really need to take it seriously. From now you have diabetes, from now you have hypertension, you need to make sure that you control those things now so that you don't end up on dialysis and you don't end up needing a transplant. And I think like that is so important for people to understand. So there's no anything that you can take that will mask kidney disease. Okay.
Thank you so much. It almost sounds too obvious to say, but you kind of have to say it. But prevention, everyone, is better than cure. And if you are dealing with hypertension, if you're dealing with diabetes, please take the appropriate steps to control it, because this does not sound, I mean, from my perspective, like an easy road at all. And we are under no illusions here this evening that is, I mean, we treat the patients like royalty, but That's after a long, arduous road. And the same goes for the donors. It's not an easy road for them either. So let's make sure that we make it worth it and get these numbers down ASAP. I see a hand in the back. Right, yeah, you're talking about you, but can you direct your mic to him, please? Don't speak until the mic comes to you, sir. Go ahead. Thanks once again for joining us for this conversation, this kidney conversation, online and on air. We'll take your question now.
Good evening.
Either.
About 15 years ago, my son had a cornea transplant. At that time, the doctor said that he was hoping and wishing that Barbados or the region should have a, as he called it, a parts bank, spare parts. And it would make life so much easier because he had to send to the United States to get the cornea for my son, which, by the way, came from a whore who was a drug addict and a thief. So fortunately, he did not inherit any of those traits. But what I'm wondering is, are we any closer to establishing this spare parts bank? And if not, what is necessary apart from the legislation? What must we do to improve and increase the chances of having this a reality? Thank you.
Dr. O'Shea.
Yes, thank you for that question. Yes, Dr. Nigel Barker has been solely responsible for a huge corneal transplant program in this country. He's done over 200 corneal transplants. And yes, all of them are imported and they cost money. And he is a huge advocate for the legislation so that, because tissue, we're talking about organs, obviously kidneys, but there's also a lot of tissue transplant that goes on as well. And there are heart valves, we have corneas, we have skin, we have bone. And there's a lot less involved in retrieving these tissue than retrieving organs, because you don't even need to be on a ventilator or anything like that. You know, you can take them after death. And yes, you will have to get the equipment and the setup to make sure they're sterilized and all of that in order to keep them. But it's something that is well within our reach, and he's very keen to, he's trained in it, he's very keen to get such a thing going. But again, we would need the legislation. So the legislation that is being proposed not only governs deceased donation and the definition of brain death, but it governs all types of transplantation, making sure that everything is done above board, that there is no coercion that Ruth alluded to, that children are protected, and also that, you know, you're not doing anything for money, like you're not taking people's corneas for money and that kind of thing. It's all supposed to be regulated, right? And there are fines in place for anything that goes wrong. So we would want to have that in place to even begin a tissue bank. But I think once that is there and it's regulated and there's no concerns on that front, it's something that we can get started fairly quickly, because it's definitely a lot less involved than organ donation. And there is a big need for it.
Dr. Scantlebury, any additional thoughts on that?
Well, you know, certainly I think, you know, the question becomes, you know, it's constantly being considered and it's constantly being on the table. The question is, as citizens of Barbados, you know, what can you do to help move the needle? And I don't know, you know, whether there's any rallying around, letter writing, or, you know, having more discussion about it, you know, maybe pulling those politicians to the table to have the more discussion about what can be done to move. Somebody's need to mute.
Yeah, someone needs to mute their mic on the Zoom. Mute your mic on the Zoom and use the chat box to ask any questions. We will be sure to address your questions. It sounds like one of you is very passionate, at the very least, to get your opinion across. We want to hear you. So please take a moment to send your questions via the chat box in the Zoom. All right, so we do have another question from the floor, Yaman. And then I have one that might take a little step into the macabre. So Brace
Right,
yourself.
thank you very much. I don't know if this is for Dr. O'Shea or who. In terms of the legislation, who has to give the permission? Is it the donor prior to being brain dead, or is it the spouse? That's my first question, and then I have another question after that.
Well, the legislation is an opt-in one where we would approach the next of kin. That is what's proposed. We would think we're not really, that, to me, that is one where you get the buy-in of the family. So whoever's next of kin, and that is defined in law in Barbados. If you're married, it's your spouse. If not, it's your eldest, your mom. If not, then it's your eldest sibling. So there, that is defined in the Mental Health Act very clearly who's next of kin. So that is what would be going for as far as legislation goes. And we would really like to be able to do living wills where you can make that decision before you die and let your family know what you want and ideally have that written down. That is really the best thing. However, that is not law in Barbados. You cannot, after you die, there is nothing that allows you to direct what happens to your body in this country. So that is something that we would like to go in tandem with the organ donation legislation. But that is not in place right now. So as it is, we would have to approach the family.
Right, so the proposal then is for both living donations as well as the spouse granting permission.
There's living is separate. Living is your life. You approach a donor and you both come and you give consent.
Right, all right.
But with the deceased, the person is dead, so we would have to ask the relatives.
Right, so my last question then is, what exactly has the Barbados Kidney Association done to lobby? What steps have they taken to lobby government for this legislation?
I think that's a question that's best answered by the president or representative. All right. So you want to speak to that now, or you want to? Okay, so right. So we will take note of that question and address it at the very end. All right, so here we go. I have a question. Or maybe two, and any of the three doctors or the goodly nurse can answer it. So my question is, are all deaths equal in terms of being able to donate? I presume based on your previous thoughts, Dr. Scantlebury and Dr. O'Shea, that certain folks who are dealing with certain issues that led to their death cannot, by definition, donate. And you did mention two examples of traumatic brain injury. You mentioned gunshot wounds, you mentioned car accidents that do lead to donation. And I think you mentioned drowning as well.
Can be, yeah.
Yeah.
Stroke, bleeds in the brain.
Right. So those kind of brain injuries are good candidates for kidney cadaver transplant. If I go and drink a bottle of Gramoxone, I'm heartbroken, I go and drink a bottle of Gramoxone. Do I count? Can I still donate? If I hang myself, can I go ahead and donate?
You have to have brain injury.
So, okay, I take a gun and delete myself with a gunshot wound to the head. Would I, because of the nature of the death, would I still be eligible to donate?
Yeah. Actually, in some parts, I think in Northern Ireland, speaking to some colleagues there, one of the biggest, unfortunately, deceased donor pools is suicide.
So you're saying that those are like,
It's still possible.
Yeah.
If you're brain dead, but even from suicide.
Right.
Yeah, they can become organ donors.
right. So that's a separate.
Again, that the family may want something good to happen or what.
Yeah, out of an
Very
awful
sad.
situation. Yeah.
Yeah.
Okay, please. Dr.
Yeah,
Scantlebury.
I wanted to, anything that cuts off oxygen from your brain.
Right.
If someone passes out from jogging or let's say, and they're no longer breathing and you do CPR where you resuscitate the patient. In the old days, you used to be able to breathe for them. Now you don't provide any breath. So you just pound on their heart and you're able to get the heart to come back.
Right.
But in the process of that whole procedure time, it only takes 3 to 5 minutes before.
5 minutes.
I mean, you can hold your breath. If you're a good swimmer, you may be able to have lack of oxygen for longer if you're
Yeah.
someone who can hold, but generally you will recover someone who have CPR and they would be able to get their heart back. And they can get them on a ventilator, but their brain may not recover because they've suffered too much oxygen loss.
Right.
And so with the lack of oxygen, then the brain dies. And it's slowly over time, you lose that heartbeat and that use the ability to breathe on your own. But you will say the patient looks fine and their heart's beating and they have a strong heart, but they don't have any more brain flow.
Right.
Drowning the same place, you have lack of oxygen. It's only difference in United States, if you drown in a frozen pond,
You can warm it.
then your body is shocked by the cold. And you're no longer having that metabolism occurring. So when you revive someone from a drowning in a frozen lake, you have to get them back to normal temperature because your heart may not be beating.
You
but
have to
may
thaw them out.
Yeah.
And so that is possible for you to recover because you then put the person in a vegetative state just by
Right.
cooling them, but they're not dead, brain dead,
my
until you
goodness.
rewarm them and then prove that they're brain dead.
Oh, my goodness.
Drinking the gramoxone is gonna damage your organs.
Right.
So it wouldn't be that, and you may not even be brain dead, but you
Yeah.
just have all this toxins in your body that wouldn't make those organs suitable.
Right.
Yeah.
All right.
And if you had cancer or if you had an overwhelming infection at the time of
Yeah.
your death, then you would not be a
Right,
candidate. for
right.
donation.
So autoimmune disease, so like HIV, would that make me a good a candidate for donation?
In United States, as long as you don't have active HIV, if you don't have AIDS, but you're HIV positive, you can donate to another HIV positive
Yeah.
recipient.
And Africa as well.
I want you to repeat that again for the hearing impaired because I was blissfully unaware of that first of all. I just figured if you were HIV positive, you would be totally off the list. But you're saying that if you're HIV positive but haven't developed full-blown AIDS, as we used to call
Right.
it back in the day, that you can donate your kidney upon your death to another HIV
Positive
positive.
recipient that's written on the list, yes.
That's fascinating. So you're saying that there's precedent for that in North America as well as in
And
Africa?
Africa, yeah,
Yeah.
because they have a high HIV population.
Yeah, right. right.
Remember, the goal is that you were still HIV positive, but you no longer carry the presence of the virus in terms of being detectable. So
Dr.
you ha-
Scantlebury, you've been around since that was first of flu scare back in the 80s. I feel very passionate about it because I lost family members to the disease and such like, and I saw how much progress we've made over these decades to know where that was. Even a whisper of you having HIV used to be a death sentence socially.
Yeah.
Much less a death sentence in the physical sense. Now it's almost like another
Chronic disease.
chronic
chronic
disease.
disease, right?
And I see Dr. Dottin jumping in there.
Because this is one of the things that I sometimes tell patients, I'm gonna say this. To me, diabetes and hypertension are worse than having
Fascinating.
HIV,
Absolutely fascinating.
you know?
And yet it's almost as if it's socially acceptable. I just got a little sugar.
Yeah.
Right.
Or
But I do not see as many patients. I do have a few, but I'm just saying, it's definitely nothing compared to the amount of patients I see with diabetes and hypertension. Because once you take your medication, which generally they do, then you don't see that complication. The issue is with diabetes and hypertension, people don't do what they're supposed to do.
right.
And then you end up with the disease, so that's actually something I say to people, before if I diagnose them, I tell them, I see more complications from diabetes and hypertension than I do of HIV.
And yet
That's
there
something I would tell people.
And yet there isn't, well, maybe it's changing now. There seems to be a lot more noise being made about how serious this thing is. These two non-communicable diseases are, rather than the whispers that probably even still obtain in some circles about sexually transmitted infections and diseases like HIV AIDS. So I didn't want to cut you off there, but I'm really passionate about that. So nurse, I want you to jump in, and I see a question. I acknowledge what you could take the mic over to her, please. Excuse me. You could take the mic over to the lady in the teal, in between the two gentlemen in white. But before she asks her question,
That's the woman in white.
That's her sister, her husband.
She would appreciate
oh
that.
my goodness, I'm so sorry. I've scheduled for an exam this month. My apologies. My apologies. My humble apologies. All right, two persons in white, yeah, but Right. Just a moment while I ask this question about your experience with regards to persons who present not knowing, I'm there for my sister, she has kidney disease. I'm there with it as the loving big brother looking to donate my kidney, and then whoops, I'm diagnosed with a non-communicable disease, or perhaps even a communicable disease like HIV/AIDS or something. What kind of process? Tell me one story that probably sticks out in your mind. That is like one of those ones like, wow, that was amazing, or wow, that's tragic. I know, I just jump on you, right? But I've been picking on my doctors the last couple of minutes. I figured, yeah.
Well,
Or you could hypothesize one quickly if you want.
okay, generally speaking.
Yeah.
So if in the workup and we find something like that, I mean, like supposing we found that your blood pressure is unusually high, you have a family history of hypertension to start with, right?
Yeah.
And you have a family, the reason why you are there is because your sister is on dialysis.
Yeah.
So you're there. And we realize that your blood pressure is unusually high. We might say it's the visit.
Yeah, white
Yeah,
coat
maybe
syndrome.
it might be the visit,
White coat
right?
syndrome, yeah.
So what I would do is arrange for you to come back on another day.
Hmm.
Like if you have any of you who've ever visited my office, it's a nice place to be. People come in, they don't want to leave. I mean, you have the ambiance, it's upstairs, it's quiet, there's some plants in the place, I don't have to fish yet. There's always brass tacks in the background, depending on what time you
Oh, sorry
come.
about your pressure.
You don't want to leave. So if in that environment and your pressure is high, what I would do is I can ask you to do a series of blood pressure readings at home. That's an option. I can ask you to go into the room and we do what we call the possibly changes. So I'll ask you to lay down, take your blood pressure while you're laying down. Then I'll ask you to sit up, and I take it when you're sitting up. Then I ask you to stand up and take it when you're standing up. And my readings that I get, I will then call Dr. Dawson, or mostly Dr. Dawson will get her first. I will call her and explain the situation to her. And she will tell me if the person go or come again another day, or we make an arrangement for them to have, I will mostly arrange the ECG that same time, have the ECG done. I want to see what the heart is doing. They might have problems going on with the heart, maybe on the nose, hypertension with other changes happening. So I want to know all these things. So when I get back all that information, I will then give it to Dr. Dawson, and she would tell me what to do. Sometimes we'll make an appointment for the person to be seen. If they're not on any medication, they will start them on a low dose blood pressure tablet.
Right.
To see how they respond. Sometimes they may have to go on 2, but if you stay on 1 and blood pressure is well controlled, we would consider carrying on with the workup.
Right.
But if you end up on 2, or maybe another one,
Oh my goodness.
you may not have, that stops it there.
Right. Right.
So then we will have to have that discussion to let them know that you're hypertensive now, and you have to do the lifestyle modifications, changes in the lifestyle.
Understood.
Yeah,
Understood.
it's not something that the person will want to hear. And I found that sometimes the most willing persons, the persons who come through my door, are bouncy and gung ho and want to do this thing, sometimes they get stopped in the tracks.
Oh dear.
Yeah, and you have to tell them, well, we can't go forward. We found something late, but not only with the blood pressure, but it may be that you had ischemic changes on the heart, or the echo was not good, you had a positive treadmill stress test, or you have problems with, when we do the CT angiogram, we realize that there's an issue with your kidneys, so we can't.
Me with your own kidneys.
Yeah, we can't
Right.
use you as a donor.
Right.
No.
Right. Fascinating. Absolutely fascinating. Lady in teal.
Yes. Hi, good night.
Good night.
I first of all want to commend the association for having this discussion. And my comment, I don't know if it's more of a comment rather than, well, I guess a question too, is I'm assuming that this may be the first of several such discussions. Maybe you've had such discussions before. I only happened by chance to find out about this. And that is why I think that education is so important as it relates to the whole transplant process, education, especially for people, life donors. I'm a life donor. And before I became a life donor, I knew nothing about, I knew nothing about transplant. The only thing in my head about transplant was years ago, Dr. Bernard, Bernard had the first heart transplant. So it seemed so out of the way transplant when my husband at the time said, they told him that he's gonna have to have a transplant. It seemed so way out to me. But as the time went on, and I became more and more educated about what a donor had to do, what the donor was, what the donor was going to go through. I became more and more comfortable. And I know that many people I knew, people that I didn't know, how could you do that? How could you go through something like that? Why would you do that? And I think that is where we have to get over, especially for life donors. I think that the association needs to have more discussions about educating people, recipients and the donors about, I don't want to say how easy it is because it's not that easy. I had an easy time. I think I was lucky. I had an easy time. Dr. Canterbury was our transplant doctor. And so we didn't have the transplant here. We had a transplant in Delaware. And it was such a smooth ride for me and my husband, who was the recipient. I mean, like 3 weeks later, we were walking the malls and doing barbecues and all sorts of things. Wow. In terms of the donor, I noticed somewhere it says, sometimes the donor has pain. I didn't have any pain. And the only medication I was given after the surgery was painkillers in case I got pain, and I never had to use them. Wow. And so I think that for the association, they need to have some more discussions so that even, I'm sure I don't know if there are other donors in here, but I'm sure there are other donors here in Barbados where we can get together and speak to those who may be thinking about it, but are afraid, because there are a lot of people. I saw a discussion on TV one night where this guy had 8 brothers and sisters and he needed a kidney, and they were all afraid to even go and test, much less to give him the kidney. They all were. His sister said, I have 7 children, I can't take that chance. So I think that education, the association needs to perhaps advertise it some more. I don't know how much they should advertise. And I think that there should be more frequent discussions, and where you have people give their firsthand experience too.
Indeed.
That would make other people feel comfortable.
I wholeheartedly would endorse your comments, and thank you very much for your donation. Obviously it was to a loved one and the choice was clear, I would imagine. But yeah, any other donors in the house tonight? So I can just acknowledge you. Any other donors who are online following the conversation? Kudos to you all. Kudos to you all once again. Thank you for that kind comment. I did have a question. I almost lost my train of thought there. While it comes back to me, do we have any other questions from amongst the audience? I see lovely lady in the back. And then we have one up front here as well. Yeah, the mic is on.
Good evening. We have another question from the Zoom live chat. And it asks, can persons with an incurable autoimmune condition be a donor qualified to receive?
Oh dear. I think you'll need to mute them respectfully. Could you repeat the question there for me, or did you all get the gist of the question?
I heard.
I heard something about incurable autoimmune, but just repeat the question for me.
Right, so they ask, can a person with an incurable autoimmune disease be a donor or qualified to receive a transplant?
Not a donor. It wouldn't be incurable autoimmune disease, but donation would be a challenge. As a recipient, if you're talking about something like lupus patients can get transplanted, but they usually have to be what we call quiescent for at least 2 years. So not active lupus. So it depends on the autoimmune disease and whether it's active or in a quiet period.
I like those words. Give me that one again.
Quiescent?
Quiescent?
Quiescent.
So that starts with a Q?
Yes.
We learn things here, see?
Sort of like in
Like
remission.
remission. Okay.
Remission.
Cool. Thank you very much for that question, Zoom.
Yeah, we've
contribution.
had patients who had sarcoidosis and scleroderma as recipients who received transplant because of the autoimmune disease affecting the kidneys.
Thank you so much. Now, my question, oh, yes, there is a young man here. Pardon me, sir.
Yeah, good night. My question is like, if you're on dialysis and you talk to a family member and they're interested in giving you the kidney, what will be the procedure forward? Like, if you got a number, a place in the hospital that you go to, on where exactly?
This is woman on my right. Is he want to ask? They're short?
Okay, I have an office upstairs on the air floor, room 15 on ward A5. That is where you can come and knock on my door. But you can also reach me, if you look at the pamphlet you have in your hand.
Yeah,
The
the
very
number
back,
is
the numbers are on there, or
436-6450, 436-6450, extension 6849, extension 6849.
And then the cell number.
And there's also a cell number. I guess you can walk that too.
yeah, well, I have, I don't know anybody yet.
Call
Call.
the cell number.
Call the cell
And for
number.
goodness sake, don't WhatsApp call.
Or you can call the operator
Or
and
just call her.
ask her to put you through to me. She knows how to find me. 2
Exactly.
ways to find me.
There you go.
Yeah.
So that number again, 436-6450, extension 6849. The cell number for your information is 256-4589.
Or if you're on dialysis and you're on the unit and you see me pass through, you can just say, hey, can I have a word with you? I will come have a
And
word
that
with you.
speaks directly to the question that you had, I presume. Right.
That was many ways
Or
to
you could
reach-
just let one of us know as well, and then
Yeah.
we will pass on the information to Ruth. That's how we will usually do it anyway.
Mhm.
Excellent.
So you just let one of us know, and then we will give her the numbers or what.
My question was a little bit on the legislation in the region, Dr. O'Shea. I understand that you are the Commonwealth coordinator for like 10 islands in the region.
Yeah.
And my question, based on your experience, what is more common, opt-in or opt-out? So I think opt-in is where I, citizen, say, I would like for you to harvest my organs in the unlikely, well, in the event that I die in the ways that were described earlier. But opt-out happens in other countries where you're presumed to have said yes, and we will take your organs unless you specifically say, no, I don't want you to take my organs. Could you speak to that, that kind of legislation with specific reference to the region?
Well, for Trinidad, I believe it is opt-in. I would say it's opt-in. Guyana, I mean, I haven't read through theirs in detail. Because Trinidad is a bit more established, and we actually looked regionally when we were drafting our own. So, but theirs being so new, I can't say for sure, but I think most people who start with opt-in. It is when you have an established deceased donor program, you start, because I know Edinburgh and the UK recently went to presumed consent after years of opt-in. And then now you can actually put your name in a registry so that once something happens to you, you end up in the hospital, they can just go and check you on a system and they know that you wanted to donate. So people usually start opt-in, and then as they want to increase the donor pool, they start to have like referendums in the country to decide whether would the country be ready for a presumed consent type of policy. So regionally opt-in, and bigger countries who've had it for a long time opt out. I would say though, even I think Dr. Comberemere mentioned is sometimes if you have somebody with a living will, and because it's such a difficult time and everybody's sad, it's something sudden, you may still get some pushback from the family. Of course. And nobody wants to have a legal battle with relatives. So sometimes even a presumed consent jurisdiction, unless you're like draconian and you just tell them, I'm sorry, this is the law, we're proceeding, most people will still want the relatives to agree and don't want to have to fight them over that, even though that's what the patient wanted. It's very difficult sometimes, and so it's good to have it and have it written down so you can prove to the family that's what their relative wanted. Even if they didn't, you may ask them, what do you think they would have said? You know them well. Do you think they would have wanted to be a donor? So there's still options. Yeah, it is. And the person who does it, I couldn't do it. I couldn't do it. I know I would cry and all that kind of thing, but the person who does it has to have a personality that they're pro-transplant, but also pro the relative, and they have to approach them with that type of, humility to get them to be on board. To do, because even after the yes, there's a lot of work has to be done. A lot of questions have to be asked about their life and what they did before they died. You heard some other things that people can do before they died, and drug addicts and so on. So you sort of have to delve into a lot of questions through a very difficult time. I've been done a course on it, and even watching the scenario made me tear up. So it's a difficult thing, but that person has training in that. And they know how to get people to say yes,
So if I die of a drug overdose, I'm a whatever addict, I would not be qualified to be a kidney donor.
If your organs are damaged, no.
But if they're not damaged,
If they're not damaged.
Okay.
Yeah, and one of the things in the United States, we say you can sign your donor card or agree to organ donation and have it written down. But it's also important to talk to your family, because that's where if they understand your wishes, they're more likely to respect them. And not necessarily have that argument after, the sons don't want it, the daughters want to, and they have these discussions. So having that family discussion and they understand your wishes certainly is there.
Understood. All right.
Online. I think this is a short one. Would a Barbadian living overseas who visits Barbados regularly, can that person be a recipient or a donor?
We're in Barbados or?
Barbados.
Yeah. If they can be, you're asking, the person is Barbadian?
Yeah, Barbadian
Yeah.
living overseas.
Yeah.
Okay.
But you would have to come back and see us and have visits, and so it's still a process, but yes, it's possible. No.
That leads to all sorts of questions, in my opinion, about medical tourism, but I'll leave it for another kidney conversation. You've been listening and you've been witness to a wonderful conversation here this evening on donors living and dead, or rather living and deceased and living rather, the way forward. And with me this evening have been Nurse Shorey, Dr. Scanterbury, Dr. O'Shea, and Dr. Dotting. You can contact the Barbados Kidney Association online by their Facebook page, Barbados Kidney Association. Be sure to like their page to show your support and give us a call. You can give the clinic a call. Be sure to walk with your pamphlets as you go. Hold on to it. You never know when you might need it. It has been lovingly prepared by Nurse Shorey, and it has a lot of valuable information that may answer any questions that you didn't think to ask tonight. I really appreciate you joining with us this evening. Is there one more question? Oh, yes. Yeah. I'm going to just, give away. I wasn't just about to.
I love that question.
Right. So you've been a wonderful audience this evening. I'll hand over to the president at this time. Thank you very much.
Thank you.
Good evening to everyone again. First of all, I'm going to deal with the question about what the Barbados Kidney Association is able to do. The Barbados Kidney Association is a very, very small organization in the process of rebuilding. I can be very straightforward. About 3 people put on this event this evening. Okay. We need help. We are committed, driven, hardworking, but we need help to grow this organization. to get my government moving on a very, very serious matter. Similar to how they did with COVID. The numbers are startling and we're not going to repeat them here. And the cost is startling also. Our AGM is going to be on the 7th of May. And we're looking for people to help us to move forward. We only have a few doctors and they're all overworked, etc. But these are the only ones that we can have to come out to you, except on a regular basis to share with you. We inviting the public. Barbados has 400 persons on dialysis. They have family, friends, and relatives. 1,000 outpatient clinics. It's ridiculous that this organization is so poorly staffed. Everybody looking at other people. Get involved, okay? It is your fight. It is our fight. It's not Alan Haynes' fight, or it's our fight. And we will get what we deserve and what we fight for. So I encourage, and I want to encourage all those who are on dialysis to get involved in the fight. There is, I tell you, there's a theory that I have. Persons we are considered as being part of a serious disease. Everybody want to move from when they're given that diagnosis, they want to move to be a survivor. I am saying there's a stage beyond survivor, which is steward, where you also help other persons. And when you get to that stage, your disease might not get cured, but you are at a different level of existence. And we need to get up from off of our backsides and start working, questioning the government. Trinidad set up a government because they recognize how important this thing was. Trinidad set up a department called NO2, the National Organization of Transplant Units, to manage transplantation. I have recommended to the minister in the Minister of State that we don't have a government department like Trinidad. No, have a combined private sector and a government department with the government resources and people who are driven with vision and don't only staff it, what I call ploppers. You could go and think what ploppers mean, but if you think about it, who just sit down and do nothing and just stir around paper, okay? We want people that are driven, that have vision, because I honestly believe, I'm an accounting profession, that this provides an opportunity unlike very few other opportunities that Barbados has in terms of cost savings, in terms of foreign exchange. We're looking for all kinds of offshore industries. And this does provide an opportunity for serious offshore business if you can regulate it properly, right? So what we are doing, the Barbados Kidney Association, we are going to continue advocating. We are going to continue trying to talk to government, but we want your help. Government does not respond to small numbers. Government is respond to votes. And if it's only a couple of y'all, government will ignore us. So I encourage all dialysis persons to get involved, encourage their family, their friends, their relatives. Government spend a lot of money on us, and we can also assist them, but we need to push them and moving forward. Politicians, though, they think that they lead, but they don't lead. We lead. We the ones that lead, and they tend to go after where the numbers are. I hope that has answered your question. I hope so. This evening, I want to thank my moderator, Mr. Jason Bell, for doing an excellent job again this evening. Yes. I want to thank my panelists, Nurse Ruth Shorey, a registered nurse, right, for explaining a very, very difficult process. It's not an easy process. And I personally understand that process from both sides. As a 20-year-old being selected by my family to give my mother a kidney, I understand all emotions. I understand the other side as a 65-year-old man now, not want to take a kidney from my 25-year-old son. I understand those things. I also want to thank Dr. Dottin, Dr. O'Shea, the effervescent Dr. O'Shea, who's always willing to help. She's one of our patrons too. She's one of our patrons of the Kidney, so always willing to help the Kidney Association. And the internationally and distinguished Dr. Velma Scantlebury for gracing us this evening with her presence. We are really honored here. These brains here, these brains. That's why we're not going to close time and get hurt, right? But they are brains. I also want to mention one of our partners, and it's good information for you. Have you all ever heard about Forlum? Everybody heard of Forlum? My goodness. That's the lady they represented Forlum. Nurse Sharon. You imagine, right? People talking, right? These folks have done so far over 1,600 free FOC, free of course, kidney tests in Barbados to Bajans. They're located in Carrington Village. Beautiful. And this, you know, sometimes when people do things free, the quality don't be too goody, you know? No, the quality don't be. Listen, I can attest it personally. I wrote a little article today. I went on to the website. Go on to the website, it's Forlum. I did Forlum.org. Right? Forlum.org. And make a booking. I went on there. Unlike the QH, when you make a booking, you don't go in there, you don't see 50 people. You know, everybody got the same appointment, the same time. No, they give you 50
Don't call
minutes.
me out.
They're giving 15 minutes. We can learn from one another. It's not anything.
Yeah.
But the hospital does work because they benefit from that, right?
And I could speak to it personally.
No.
I set an appointment for next Friday for my second.
Your second kidney test.
Kidney function
Yes.
test.
No.
And so it was really efficient.
Yeah.
way to say
It was very efficient.
Yeah.
And there's not
you do it yourself. You know,
I'm not
it's-
knocking hospital. The hospital does. I mean, you can't knock the hospital.
Certainly not.
The QH will has me here today.
We learn from the best of
here.
both
Let me
worlds.
stand up here so I don't knock the hospital. And then after God, the equipment, them nurses is the way love and thing, all them, you know, they have me here stand up. So I don't knock the QH at all. I'm one of those people.
At all.
Yeah, at all. Right. But it was a very, very, what you should say, easy task. When I got there, only 2 people in front of me. And my son here, who's autistic, now he ain't like me and soft like me. When he tense up, you look at him again, his hand. And the nurse was so patient and loving it. It was a very, very pleasant experience. And they had to write Mr. Lambert and tell him that it was. And they were not doing it because they recognized me, because I turned up there, they didn't know me. They didn't know me from Bilko who he was. Okay? So I would advise you all to get your relatives tested.
And get yourself tested.
I get yourself tested too. Like you see, I take it myself because I get the medicine testing me. But yeah, get yourself tested. What I have also been doing is trying to encourage the government. There's a program called KEEPS, American program called Kidney Early Evaluation Program. And me and my creativity put Barbados in front and call it KEEPS. And what we're trying to do is to get the polyclinics, the GPs, for them to continue. Or this like for them to continue. Get the Kidney Association to hopefully get some nurses involved that they can do the testing so that it can take some of the pressure off for people like Dr. Dauphin and them. And then you will get, when you discover that you have a problem, you will then refer to them. But don't go to them with the people that got stage 1 and 2 to waste them time. No, they're specialists. You understand? And they need to deal with you when it gets serious so that you get a wider spread. That's one thing. Another thing, I've spoken to BAM. We've been working over here. I've spoken to BAM. We want to have 2 other persons brought into the management of kidney disease. One, a patient who has gone through the process before, or and has a certain level of success. Because the reality is that once you are given this diagnosis in the early stages, most people get depressed. And when you're depressed, you will not be a compliant patient. So you need help, especially in the early stage. Don't care how great the doctors are. If you're depressed, even when she's talking, you ain't hearing her because your mind elsewhere, So we want a patient who has gone through it, but that patient is not a professional, and also psychologists. So those 2 additional persons, we will like to see brought in the process in the early stages when you get that serious diagnosis, because as the doctor pointed out, most people don't know that they have kidney disease until they end up in emergency, and they have 2 weeks to go on dialysis. So anyhow, we continue with, I want to also thank Tech Media. These are some guys that I met very recently, and I will be using them a lot more because I know enough. I know enough. I can't even get a phone operator too good. So, but they have been here, and I appreciate what you all guys have done. I hope, yeah. And I also want to thank online. There's Dr. Hasina Mohammed from Trinidad. She is assistant to the Dr. O'Shea in the Commonwealth, coordinator Commonwealth Tribute to Life program. And we are going to be, next time we have one of these sessions, we will get some folks from Trinidad so we can learn from some of their experiences. So next time, invite a friend to come out. We will get in some persons from Trinidad to bring some of their experiences. And we may have 1 or 2 patients on that also. Recently, we had in Barbados 2 transplant recipients and 2 donors that were interviewed, and we can have that tape available or not, whatever, not a tape, sorry. Oh, that's dating me, sorry.
The correct term is audio, sir.
Audio recording, let me put that right. We will have an audio recording of that available for you to watch. Unfortunately, we had some technical issues during that session, and we did not get a recording of my sister who had a transplant for 45 years. We want to hear her story. Yeah. She's one of the longest, and based on my investigations, there are only 2 other people in the world who had a kidney transplant longer than hers. A guy in France and one in England. There may be some others, but I'm not aware of them. So I also want to thank you audience, those here for coming out to Comberemere. I also want to thank, we had like almost 48 people, I think, online, right? This was a nice number. We also want to thank all them online, though we had some from Antigua, we had some from Ghana. We thank you for joining with us. And we hope that you would invite your friends to next time we can double these numbers as we try to spread this news with our small numbers. But I invite you to join the Kidney Association. May the 7th, turn up. We are going to be all online. So turn up and have your say on the map. Did I miss anyone else? So after, you can go over to the table. I think she has some information over there that she will share with you from Forlam, our partners. So again, thank you. Get home safe. May God bless you.
Thank you. Bye, everyone. Take care.